want to start mentioning the hypothalamus because it does play a major role on controlling the hormone release from the pituitary, and the pituitary acts on so many other glands throughout the body. So the hypothalamus really does play a major role. There is a table in your textbook, 47-2 for the 11th edition, and it does list the releasing and inhibiting hormones from the hypothalamus. We are really mostly going to just talk about corticotropin releasing hormone, so CRH, which plays a role in stimulating the anterior pituitary and then the adrenal glands, and the thyrotropin releasing hormone, which again stimulates the anterior pituitary and then the thyroid gland. There's some other, growth hormone that releasing hormone. There's some inhibiting hormones, but those two that I mentioned are the ones that we'll talk most about. Okay, so for this voiceover PowerPoint, we are going to cover the pituitary gland, go into a little bit more detail with the different diagnostic studies for the disorders that we're covering. The anterior pituitary has numerous hormones. The posterior pituitary, just a couple. And we'll go over those on the next slide. And we're going to cover one major disorder of the anterior pituitary and then two very common disorders of the posterior pituitary. And these can occur in your neurologic population, your psychiatric population, oncology, post-op. So if you are planning on working in critical care, ED, post-op, a variety of different areas, you may actually really see some of these posterior pituitary disorders that we're going to talk about. So I'm trying to be helpful here, and I highlighted the hormones that I really want you to focus on from the anterior and the posterior pituitary. So TSH, ACTH, and growth hormone. Really know how they stimulate whichever gland and hormone, or how the release is inhibited, and how it acts on the body. The end action would be important. The posterior pituitary, when you take nursing 103, maternity nursing, you will definitely spend a lot of time on oxytocin, but for 104 we are really focusing on antidiuretic hormone, ADH, and again, the second half of the semester you'll hear Justin talk a lot about ADH as well. So this figure is right out of your textbook, and I put it in here because it is kind of nice to see the relationship between the hypothalamus, the pituitary, and the target organs, just to help organize everything in your mind. So now we're finally to our first disorder, and this gets a lot more interesting when you start talking about clients with certain conditions, what's going on in the body, what sort of symptoms are they having, and how do you treat it. So acromegaly is the one disorder that we're spending time on with the anterior pituitary. It's involving the growth hormone, and it's a hypersecretion of the growth hormone, and that occurs after the closure of the epiphyseal shaft or the growth plate. Most often it's caused by a pituitary adenoma that is causing this hypersecretion of growth hormone. It is a benign tumor, and it causes overgrowth of soft tissues, the short bones in the hands, feet, and face. And this is a very slow process. So this is an example of something that you might see over 10 or 20 years. versus a very sudden disorder. This is an age progression photo of a client with acromegaly, so over a period of greater than 20 years, and you can see physical changes to those facial bones. So coarse facial features, the forehead. You can see a lot of tissue overgrowth. So clients may actually have a significant increase in their shoe size, have very large hands. Their tongue may be enlarged. You may notice speech problems, deepening of the voice due to the overgrowth of the tissue and the vocal cords, sleep apnea. Clients may have chronic pain in their joints. They may have symptoms of diabetes mellitus, so that polyuria, polydipsia, because growth hormone opposes the effects of insulin, so it causes increased blood glucose levels, so hyperglycemia. And due to that, there's a lot of cardiovascular complications, and that's really the number one, the most serious complication of acromegaly. So diagnostics for acromegaly, they're going to measure growth hormone levels, but again, that's not a steady release of hormone. So you're not going to get great information just measuring growth hormone level. Insulin-like growth hormone level is a steady secretion, and that will give you better information, so a measurement of the insulin-like growth hormone factor. One test that I want to go over is the oral glucose challenge. So I know perhaps many of you may have had this test done if you were having a workup for diabetes or with pregnancy. So you drink an oral solution that has 75 grams of oral glucose. Prior to that, you have baseline blood work drawn, and then after you consume the oral glucose solution, growth hormone levels are drawn every 30 minutes. And normally, when you drink glucose, you would see decreasing growth hormone levels. With acromegaly, you continue to see elevated growth hormone levels on those measurements. So that would be one diagnostic test for acromegaly. Also radiology. So like I mentioned, CAT scan, MRI, because the most common cause is that benign tumor, the pituitary adenoma. So it would be to detect that in the pituitary gland. So the surgery of choice for a pituitary adenoma is a hypophysectomy, so a lot of times a transsphenoidal hypophysectomy. Post-op nursing care is very important with this surgery, and I just want you to kind of think about the location of the surgery. This is very scary for clients. It's considered brain surgery, and there's a lot of complications that can occur because of the surrounding tissue and gland and all of the different hormones that are secreted by the anterior and the posterior pituitary, so just kind of keep that in mind. So we'll just go over the post-op nursing care. So definitely frequent vital signs, neuro checks. You're definitely going to want to accurately measure intake and output. And I want you to think, why would intake and output be so important with this surgery? I know it's important as a post-op consideration for all clients, but when you're thinking about the posterior pituitary and antidiuretic hormone, urine output's going to really give you an early indicator that there's a complication involving ADH. So accurate INO is a really big one. The client will have nasal packing. So I'm not sure if any of you have ever cared for a client with nasal packing, perhaps for another reason, maybe an uncontrolled epistaxis or nosebleed, where a client has like a rhino rocket or packing in their nose. Very, very uncomfortable. There's a lot of pain, pressure. It's difficult to drink, to talk, to sleep. So that can be very uncomfortable for clients. So these clients would have nasal packing. They would have like a mustache dressing as well, and you want to closely monitor for any drainage. If there were any drainage noted, you would want to test the drainage for glucose, because it could be a cerebrospinal fluid leak. So that would be important. Frequent oral care. So there is actually a surgical incision, oral incision. So brushing teeth is kind of discouraged for 10 days, but really good oral mouth care is important to prevent infection and good oral hygiene and any further complications. So using those mouth swabs and mouth rinse and really good oral hygiene is important. We would definitely want the head of the bed elevated to help decrease that intracranial pressure. And we want to decrease the risk of any complications with increased intracranial pressure by teaching the patient to try to avoid blowing the nose, avoid coughing. This would be a situation where we would not want to encourage deep breathing and coughing, sneezing, vomiting, straining. So we would want to have the client on a bowel regimen pre-op, treat early with antiemetics, anything that we could do to help decrease the risk of any increased ICP. I mentioned that this is a very scary surgery. And again, clients may have had a very long journey to their diagnosis, so they may be dealing with a lot of chronic pain, physical changes, fear about the surgery, and the long-term effects of this treatment. So providing a lot of support and education on follow-up, because this can always reoccur. The pituitary adenoma can always reoccur, so they really need lifelong follow-up. So this is image is just showing you the transsphenoidal approach for the hypophysectomy, which is very common. So if a client is not a surgical candidate, or the tumor is so large that they may want to shrink the tumor prior to surgery, radiation might be indicated, and that would be localized radiation to help minimize the damage to the surrounding tissue. Another treatment that may be preoperatively or for a client that's not a surgical candidate would be drug therapy. The most common would be octreotide, and that actually decreases the production of growth hormone, so it actually eventually inhibits the production of growth hormone. It is administered sub-Q 3 times a day. They do have a longer acting octreotide that's out, that's IM. Most common side effects are alterations in glucose and diarrhea, nausea. Dopamine agonists are oral medications that decrease the secretion of growth hormone. Most common side effect would be headache. And the growth hormone receptor antagonists bind with the growth hormone receptors. They don't actually do anything with growth hormone release, but they prevent the effects of growth hormone. and the most common side effect would be headache and fatigue. But again, the most common would be octreotide, and this would only be used in conjunction with surgery or if the client was not a surgical candidate, but the treatment of choice is that hypophysectomy, the transsphenoidal hypophysectomy, so really understanding that surgery and the post-op nursing care would be important to focus on. So there's so many different hormones from the anterior pituitary. We just talked about one disorder involving growth hormone. Hypopituitarism could be any one of those hormones, a hyposecretion. If it's all of the hormones, it's called panhypopituitarism. That is very rare and is a life-threatening disorder that requires daily hormone replacement of all of the hormones, and it's lifelong, so it's very costly and requires a lot of monitoring lifelong. So if we were thinking about specifically growth hormone, a hyposecretion, that would just be one example, and the client would need growth hormone replacement. So the growth hormone injections usually would be given in the evening because that's during those night hours or the early morning hours or when you have a surge of growth hormone. So the timing of the onset, you would teach your parent to administer these injections daily in the evening. If it was involving TSH, depending on which hormone from the anterior pituitary that there is a hyposecretion, the treatment would be specific to replacing that hormone. So we're going to move now to the posterior pituitary. And again, the one hormone that we're really focusing on is antidiuretic hormone. And for some reason, that seems to be a hormone that some students struggle with. So I want to just go over antidiuretic hormone right off, try to have a solid understanding of antidiuretic hormone, and then you'll be able to kind of talk yourself through a hypo or a hypersecretion of ADH. So major role of ADH is fluid regulation, so water balance. And ADH is stimulated by increased plasma osmolality. That would stimulate the release of ADH from the posterior pituitary, which would act in the renal tubules to cause the reabsorption of water, which would increase volume and inhibit the release of ADH. So ADH is all about water balance. I don't want you to be thrown off by the term osmolality. It's really just the measure of solute concentration in circulating blood. So if you have increased plasma osmolality, that means that you have hypovolemia and you need to increase your fluid volume. So that's why you want to stimulate antidiuretic hormone to help increase the volume. ADH is a potent vasoconstrictor as well, so I just wanted to add that. And I also want to add the role of ADH in blood pressure regulation. So when we talk about hypertension later in the semester, a lot of these hormones come back because of the impact on blood pressure. And that's another, so decreased blood pressure so hypotension would stimulate the release of ADH as well. So first we're going to start with hypersecretion of ADH, so increased secretion of ADH. syndrome of inappropriate ADH. So you'll see that abbreviated as SIADH. And this really causes problems with fluid balance. So you have increased water reabsorption in the renal tubules, increased vascular volume, and we're really concerned about sodium. So when we talk about the disorders of ADH, because its major function is on water regulation, that's the main electrolyte that we're going to be looking at is sodium. So I want you to just kind of think to yourself, what would these patients look like if they had hypersecretion of ADH and they were retaining too much fluid? What sort of symptoms clinical manifestations would you expect? So causes of SIADH, certain cancers, so colon cancer, pancreatic cancer, prostate, lung cancer. There's actually bronchogenic secreting ADH secreting tumors where the tumor is independently secreting ADH and contributes to the hypersecretion. So again, if you work with the oncology population, definitely something that you may see. Certain CNS disorders, so brain tumors, head injuries, Guillain-Barré, meningitis, stroke, so a variety of different neurologic disorders. Certain drugs can cause SIADH, so anticonvulsant, such as carbamazepine, certain chemo drugs, tricyclic antidepressants, opioids, so some very common medications, even certain anesthesia. And then there's some other conditions that could also cause SIADH, infections like TB, COPD, HIV, so quite a few different conditions that can cause SIADH. So hopefully when I asked you to kind of think what would your client look like, what would if they presented with SIADH. So definitely fluid retention, they're going to have increased body weight, decreased urine output. So their urine output is going to have an increased specific gravity. We really are looking at sodium when we talk about ADH because of water balance. So hyponatremia. So the symptoms of muscle cramps, weakness, nausea, vomiting, lethargy, seizures, those are all related to hyponatremia. Obviously the lethargy, seizures would be when that becomes critical. So diagnosis is made by urine and serum osmolality, looking at sodium level and the physical assessment, the history. Treatment is immediate fluid restriction and a severe fluid restriction, like might be 800 mLs per 24-hour period of time. So anytime your client has a fluid restriction, make sure there's no water pitcher at the bedside. Make sure you're accurately communicating the fluid restriction with the team you're working with, so the tech you're working with, the patient, the family, because they will have thirst and really be wanting increased fluid, and that's a pretty severe fluid restriction. Strict INO is going to be important. Daily weights, using the same scale first thing in the morning. Seizure precautions for if your client is severely hyponatremic. Positioning the patient flat to promote venous return. Clients may require diuretic therapy if they have, due to the excessive fluid retention. Let's say they're having crackles, bibasilar crackles. They may need some diuretic therapy, you have to be very careful assessing the sodium level to make sure it's not critical, because it will cause further sodium loss, the diuretic therapy. If a client is critical with their hyponatremia, they may require a replacement of a hypertonic sodium solution. So really, it depends on your client. There's also some drug therapy, which decreases the responsiveness of ADH in the renal tubules. So conivaptan and tolvaptan are two newer medications that can decrease renal responsiveness to the ADH. And then that underlying cause. So if it is a cancer, treating the tumor, a medication, weaning the client off the medication, an infection, treating the infection. So whatever the underlying cause is, that's also a part of the treatment. So the last pituitary disorder that we're going to cover is diabetes insipidus. So first I want to point out that this has nothing to do with glucose or diabetes mellitus. It's diabetes insipidus, and it's all around ADH, water regulation, and we're really concerned about that sodium. So this is a hyposecretion of ADH or a decreased renal response of ADH. So if you want to remember the D in diabetes insipidus and D for decreased ADH, that's what's going on here. There's not enough ADH. So decreased water reabsorption in the renal tubules, decreased fluid volume, and it's again causing fluid and electrolyte imbalances, especially that sodium. Causes of diabetes insipidus can be central, nephrogenic, or primary. So central involving the brain, so trauma, tumor, a CNS infection. It could be secondary to surgery or radiation to the pituitary gland. Nephrogenic could be a problem with the renal tubules and their inability to respond to ADH. It could be primary diabetes insipidus, where a client is having excessive water intake. So it might be a lesion in the thirst center, or it could be a psychiatric disorder. I actually had a client with primary diabetes insipidus and just obsessive about water, and really contributed to the development of diabetes insipidus. Just was compulsive about drinking water, and would beg family visitors for other patients on the unit for water, the housekeeper, anybody that was walking by. They were constantly trying to sneak water from the water faucet in the bathroom, and it was really something. So that definitely can occur, especially with your psychiatric population. So these clients are have excessive thirst, so that polydipsia and the polyuria. Those are also common symptoms with diabetes mellitus, but again, this is different. So their urine is very dilute. They can have up to 20 liters a day. So they're really losing a lot of fluid. They have increased serum osmolality, decreased urine osmolality, decreased urine specific gravity, and they are hypernatremic. So they're hypovolemic, hypernatremic. So I want you to think about all those symptoms of dehydration and what your client with diabetes insipidus that has decreased ADH hormone or effect, and has all those symptoms of dehydration. So the tachycardia, the hypotension, the decreased skin turgor. So I'm just going to go over the diagnostic and treatments for diabetes insipidus. So most of the time the diagnosis is made on a history and physical assessment, urine output, urine specific gravity, sodium levels, weights, and they would have enough information with a thorough history to determine the cause and diagnosis for diabetes insipidus. In a case where they're unsure if it's a central cause or a nephrogenic cause, so if there's a problem with the brain or the kidneys, that's when they would do a water deprivation test. And this test would be done in an inpatient setting. Fluids are held for a number of hours, and then a synthetic form of ADH, so desmopressin or DDAVP, would be administered, IV, and then the client's urine output would be monitored. If the client responded to the DDAVP, so let's say they had a sudden reduction in urine output, that would mean that there's a problem with the pituitary. So there's a central cause of the diabetes insipidus. If there was no change with the urine output, that would mean that there's a nephrogenic cause. So the kidneys are unable to respond to the synthetic ADH. So treatment would be immediate hydration, so like a D5W, strict I&O, frequent vital signs, daily weights, first thing in the morning, same scale, same time, really closely monitoring those electrolytes. You would want to decrease sodium in the diet, and then depending on the cause, that's how the drug therapy changes. So if it was a central cause, then the client would need replacement, lifelong replacement of ADH. So DDAVP, the synthetic form of ADH. If it was a nephrogenic cause, clients may receive a thiazide diuretic. That's going to decrease blood flow to the ADH sensitive nephrons and cause decreased urine output. They may also order indomethacin, which is a medication that will decrease the renal responsiveness to ADH and therefore cause a reduction in urine output. So I apologize, I just said that last statement backwards. So indomethacin would cause increased renal responsiveness to the ADH and therefore cause decreased urine output. And we can go over any questions that you have on SIADH and diabetes insipidus when we have our live session next class.